This is the Tox Course Podcast. Welcome back to the Tox Course Podcast. Andy Buck here. We actually recorded this episode as part of the paid Tox course at etmonline.com. But we put our heads together and we felt this was actually so useful and so good that we should actually just share it for free on the podcast. Acute behavioural disturbance is a common problem in EDs, and based on the recent Australian Criminal Intelligence Agency wastewater survey, which showed increases in recreational drug use across Australia, and in particular in methamphetamine use, and I've done a post about this on the wastewater data, which you can actually read on the toxcourse.com blog, this is not a problem that is going away anytime soon. There's also a lot of misunderstanding in the emergency medicine scene about what your responsibilities are when you're confronted by an agitated, drug-affected patient who wants to leave the ED. So in this episode, the creators and main presenters of the Tox course, Ingrid, Berling and Nick Dafters, take a deep dive with me into managing acute behavioural disturbance in the ED. And we cover everything you need to know about personal safety, medico-legal issues, and where your duty of care starts and stops in these situations, capacity and consent, and pharmacological and non-pharmacological management of the acutely behaviourally disturbed patient in the ED. So without further ado, let's launch into it. This is Ingrid Berling, Nick Dafters and myself on managing acute behavioural disturbance in the ED. Patients presenting to the emergency department with an acute behavioural disturbance in the setting of recreational drug use is an unfortunately daily occurrence in most EDs around Australia. It's a very common presentation. It can be difficult. It can pose a lot of challenges to staff due to sometimes just the simple nature of the physical threats involved, but also there's elements of medico-legal responsibility and also some major clinical concerns with these patients. So you need a detailed and structured approach to that. So Nick, you have a patient who's coming to the emergency department, appears behaviourally disturbed and likely under the influence of an illicit substance. What's your general approach to these patients?
This area is really huge. It's a real minefield and it's part of our daily core business. Over my 20 years in clinical practice, I've seen this situation managed very, very well, but I've also seen it managed quite poorly, leading to quite bad outcomes. And we've all seen instances of staff members being injured, sometimes with permanent effect on their ongoing ability to practice. So it's an area that requires true expertise and experience to do really well. I think if I was going to start anywhere, what I usually would do is take a step right back from the situation and observe the patient from a safe distance, because my role would usually be the clinical leader in charge. And I need to make a quick assessment as to whether this is an urgent behavioural emergency requiring a full response, or whether this situation can potentially be brought under control with some verbal de-escalation. So I would step back and make a rapid assessment of, am I safe? Are my staff safe? And that would be my first decision node from there.
Yeah, that's a great way to differentiate it. I think I do a similar thing. I think we could unpack that a bit, though, about how we actually do that, because I think people who aren't as experienced sometimes struggle with that just initial contact, that initial assessment of, does this appear someone who's safe for me to approach and just have a conversation with, find out what's wrong and see if we can de-escalate, or perhaps myself and a nurse, a couple of people? Or is there an element of threat? Do we need a security presence with us while we do that, just even across the room assessment? How do you there's an element of just intuition and experience and probably doing it wrong a few times over the years and learning the hard way, but how do you make that initial judgment call?
Yeah, I think what I've learned the hard way over the years is call for help early in these situations. The main risk would be trying to get involved in some combative verbal de-escalation with a patient who's just not winding down, and then you're stranded potentially by yourself, or watching another junior colleague or nursing member of staff having that same problem. So don't leave people isolated in that scenario. So over my career, I get quicker and quicker at pulling the emergency buzzer. So there's some clearly defined markers for behavioural escalation and some clues, but it is worth also remembering that people can look completely calm and then have a sudden attack of rage and assault someone. And there's been videoed instance of that in Australian emergency departments where a completely benign looking patient rapidly assaults someone and puts someone in a chokehold. So we have to be mindful that you can never be 100% confident with anyone's behavioural response in this scenario, but I would advise everybody to call for help early and often. Sometimes if you do call for security assistance, it's reasonable to have them observing from a distance rather than getting straight into the scenario, because there may still be a window where you can de-escalate a patient and the security presence isn't always helpful. But I'd much rather have them there at very short notice, a few arm lengths away, to intervene if the situation escalates.
Yeah, I'd do a similar thing, and I've learned over the years as well. It takes a bit of practice and experience to learn what someone who is perhaps has some needs or expectations that aren't being met, perhaps due to a long wait. They're getting frustrated, and that frustration tips over into anger because of something reasonable. Their kids, they've got a child with them, and their kid's crying, and they want the child to get seen. Or the kid's hungry or crying, or they've got somewhere to be, they've got a family member who's unwell. There's something that tips them over. And I often try and teach junior doctors that most anger comes from frustration, and frustration comes from unmet needs and expectations. And you can circumvent a lot of anger by empathising with the person. I understand you're feeling frustrated. Can we figure out why, and what can I do to address that underlying cause? And that type of patient is usually a bit more obvious. That someone who's been in the waiting room a while, has come and pestered the nurse a few times and is getting increasingly frustrated, and if you can address that need or expectation, it often just cuts that frustration out and saves the anger happening. Or is this someone who has just already gone into the red zone, whose expectations might be unrealistic, or their judgment and what they think they need is impaired by being intoxicated, for example, who you just aren't going to be able to rationalise with or get to that underlying need with, and do you need to step in a bit quicker? And I think that does take a bit of time and practice, but if you just think about the tone of voice, a quick snapshot of the person. Is this a young homeless man who clearly is drug affected, who's dressed in filthy clothes, who you've got his name, you've quickly looked up on the system, he's got multiple mental health presentations, multiple drug and alcohol presentations? That's a very different customer to someone who is, a fresh customer off the street who's come presented for a simple medical problem, who may be slightly drug affected, but doesn't have all those other red flags, isn't being particularly violent, just wants something. And if you can provide that want, you might actually diffuse it. But I agree with you regarding security, etc. Ingrid, so what about you? What's your general approach if you've got someone who's a bit agitated with regard to getting security or not, and how you initially approach these people, how you do that initial assessment?
My approach, Andy, is similar to Nick. So I like to stand back and get a picture of the situation. And I think the foremost thing in my brain is safety. Safety for myself, safety for my staff, safety for the patients, and also safety for the patient who's escalating in front of me. And I think once you've determined that you feel safe, and that may be by calling to have security in the back there, just giving a presence that may help to de-escalate the patient, and you feel like you're ready to go in and sort of address the situation, then you need to make sure that you're going into a space that you still remain to feel safe in, so that you aren't obstructed from the exit at any point in that interaction, but also making sure that you don't make the patient feel more unsafe in that environment. So a body language approach is also important. You don't want to go in there with aggressive body language. You don't want to go in there front on, really intimidating the patient.
Not pointing or gesticulating or getting too close.
Exactly. A hands back behind your body approach, maybe standing side on, keeping a calm and slow voice is at least a starting point to try and help de-escalate the situation.
So once you've done that initial assessment, and sometimes that can happen from across the room, or from a not too close to the patient space because of this issue of physical safety, and you've done a bit of a snapshot, you generally will be making a next assessment about does this person have capacity to cooperate with whatever treatment or investigations that I think they might need, and can they consent to it, or are they clearly just so unwell that they can't? So Nick, how do you go about this sort of initial, because if you decide very quickly, well, this person needs an intervention that they appear unable to consent to or lack capacity to, it's going to turn into a sort of an involuntary treatment situation. How do you approach that with these patients?
It's a really common situation in practice, and once you become a specialist in emergency medicine, it's a decision that frequently you're making, and I think it can be quite confronting. I certainly found it challenging when I was in more junior roles to rapidly make those assessments. Really what we're speaking to is under what grounds can you potentially intervene with someone against their consent or without their formal consent. So really there's only two ways that happens in Australia. One way is under the Mental Health Act, and the other way is under the concept of duty of care. And it often is quite confusing for people what the differences between those two things are. And the real issue at the heart of it is the Mental Health Act itself stipulates quite carefully that drug affected or being drug affected isn't a grounds to use the Mental Health Act. So what duty of care really means is there's no formal legislation governing the particular situation you find yourself in. And pragmatically, there will never be, because there's each unique situation with each unique patient needs to be addressed separately. So what it means in practice is you have to make a good faith, common sense and ethical decision based on the information in front of you. And if someone was to query that decision legally, your decision would be questioned against previous case examples and common law where there's been a similar situation before, and ultimately that could be assessed in a court of law. Pragmatically, in my 20 years of experience, it's vanishingly rare for a physician or emergency physician to be brought up to have to answer for one of these questions. But I think we need to make every decision based on the fact that we could justify that decision based on our perception of the risks of the patients and the public. And if you're making a good faith ethical decision within those parameters, it would be very hard to see a court or a jury disagreeing with your assessment in the moment when you were the most senior person there.
It's really important to document your capacity assessment as well. If you're going to act under this duty of care system, you have to assess the patient as lacking capacity to make their own decisions. And that can be done across the room sometimes. You don't necessarily have to spend hours there with them. It can be done quite quickly with a bit of experience. It's worth looking up yourselves what capacity assessment involves. It's a very simple process really of can the patient comprehend what I'm saying to them, process it and reiterate it back to me in a way that implies they understand what's going on. Some patients, perhaps who are drug affected, perhaps those say on amphetamines, this can be a bit tricky as well because they may appear to take in what you're saying and spit it back out at you very quickly sometimes, confrontingly so sometimes, and that might make it a bit challenging. Other patients who are clearly sort of in a drug-induced delirium as such, it's very obvious that they aren't possessing those faculties, and you can then go ahead and say, look, I think this person lacks capacity. And remembering too that capacity fluctuates, it can change. So just because they lack capacity when they come through your door, you may do some treatment, the drugs may wear off, and after a few hours, patients regain capacity, and you may find yourself at that point needing to do a reassessment and redocumentation. And again, like you've said, should you ever be questioned on this, as long as you've documented this clearly in your notes, you're generally going to be okay.
Yeah, I think capacity is another area which is legally challenging for us as clinical practitioners. There is a formal definition of capacity, which is used in situations where someone's right to look after themselves with early onset dementia. That's the situation where a formal capacity assessment can be involved. And that's a process that's not relevant to the acute behaviourally disturbed patient because it requires proper lengthy reviews involving psychiatrists. What we're doing, I think, and what we must document is why we think the patient is unsafe to just leave. And I think that's something that we are experts in. And frequently it's just the obvious common sense things like the patient is stumbling around the ambulance bay, they've got no rational plan to get home or even know where they are, and there would be a clear risk of them walking in traffic or falling over and sustaining a significant injury if they left. So I think we can fall back on common sense and document why you're worried in the moment, and that would always reflect well on your decision down the track.
And people do forget to document those simple things, even just a description of how the person appears. They appear intoxicated, they're stumbling, they're falling into walls, they're clearly a risk to themselves. And again, that will help back you up should you decide to keep them or treat them against their will. Some patients, however, when you make this decision, will disagree with your assessment and say, no, thank you. Actually, I'd rather leave now. And then you're faced with this situation where your decision to stop them leaving may escalate things. So I might just talk for a minute about personal safety and a fear people have as well, I think, about letting people go. So the person might just be angry and agitated and drug affected, but might actually be okay to leave. Even though they're maybe at risk from their drugs on board, they might be okay to go out on the street. Medical people often get confused about what their duty of care to that person is and at what point that can possibly stop. And the threat could become so much from the agitated person that the threat the person's posing actually overwhelms your duty of care, and it's actually okay to just get the person out of the hospital because it's not safe to actually have them there. So Ingrid, you mentioned things like just being in a room where you have access to the exit, your stance, your tone of voice and things. Is there any other things you do when you're thinking about personal safety and this risk that the patient might assault you in their attempt to leave?
Certainly once it's getting to that level of escalation, Andy, then I'm starting to think about having a team response to this situation. I would be activating my security alert alarm and making sure that I have senior nursing staff and other personnel on around to help me to contain the situation. You would need to make sure you have a clear idea of the environment that you're working in. A lot of things in the emergency department can be weaponised. You want to make sure there's not a loose chair or something that can be picked up by the patient and thrown at you. Similarly, things that we carry on our body can be weaponised. Many nursing staff carry scissors on their persons, and doctors and nurses can have lanyards that can be pulled and put them into a choke hazard. So before approaching a highly escalated patient, I would be removing all of those potential weapons.
It's important, isn't it? I mean, a lot of us wear lanyards that have a plastic clip that breaks if it's pulled for that specific reason. So I agree. Things like take your stethoscope off, put it away somewhere, take the pens out of your pocket, take your badge off, put it in your pocket, those sort of things, removing weapons. And I've seen all sorts of things used as weapons in emergency departments, as I'm sure you both have, from food and drink, cups of tea, cutlery, medical implements, defibrillators, trolleys. In the old days, we used to have chest tubes with trocars in them, and a patient I was involved with once found those in a resus bay, opened them up and used the trocars as weapons. So doing as best you can to make the space safe is important, isn't it?
That's right. And from there, you continue, but at any point, if you feel like the situation is escalating to a point where you don't feel that it's safe to contain the situation, or you feel that yourself or any of your staff are threatened, then it is okay to step back and allow the patient to leave.
Yeah, no, that's a really important point that I think people forget. In this situation, people can overwhelm the resource that you have available at the time. Either security hasn't arrived yet, or you've had to call the police, they're not there yet. Or security is there, but this person's so violent they're going to overwhelm you guys. And at that point, it is actually okay to open the door and let the person go. We might dig down on this a bit more because this is a really important point that people stumble on quite a bit, because a lot of medical staff and a lot of nursing staff, I find, are overwhelmingly convinced that their medical duty of care is infinite for this person. And if they've made a decision that initially that they need to stay, then they have to do everything, potentially including standing between that patient and the door, physically grabbing the person to stop them leaving, or locking the door or something to stop them leaving. That's something they have to do, because if the person were to leave and come to grief, they run in front of a bus or pass out an overdose on the street, that they can somehow be held individually responsible for that. And that's a real myth that I think we need to bust right now, because you can't. You need to absolutely, as Nick said, be acting in the person's best interest, but there is nothing that says you have to put yourself between a violent patient and the door or the exit, or put yourself in harm's way at work. You're entitled to a safe workplace, and that you're also entitled to be able to do your job in a safe fashion, which means if someone's violent and angry, you don't just walk up to them and say, hey, I have to examine you, and get close enough to them to get hit. The hospital has an overwhelming duty of care to that patient, meaning that they need to provide security who can contain that person, or perhaps act as a barrier between you and the patient, so you can do your job, which is clinical assessment and prescribing treatment. You're in no way obligated to physically grab someone to stop them leaving ever, or get in any sort of physical altercation with the patient who wants to leave. And if the hospital can't provide what that patient needs, which is containment, then you as an individual can't be held responsible. If you find yourself, and sometimes these situations escalate rapidly, don't they, Nick, where it might just suddenly get violent very quickly before security is activated, and you'll be faced with this decision, and someone's walking towards the door and you're between them and the door and you think, I feel like I have to stop them leaving, but Andy said I shouldn't. What should clinicians do in that situation?
I would consider that I'm lucky enough where I work to have an extremely well-drilled response to this, as it's something that we see on such a frequent basis. And that being said, I'd like to just reassure everybody that there are still patients that overwhelm our response and we allow to leave. The typical situation would be someone who's primarily intoxicated. Probably the most common things that trigger this would be alcohol and potentially methamphetamine. And if you have someone who's 6'6" tall, very muscular, extremely elevated, hasn't responded at all to verbal de-escalation,
is perhaps squaring up for a fight.
And every signal that you're feeling is telling you that this patient's about to become violent, and their main agenda is they just want to leave. Absolutely, you let them walk out. Your duty of care hasn't completely finished. You would then, of course, notify the police and say, look, we've had an extremely violent patient in the emergency department who may need further care. Can you please go and find them and bring them back, under safe circumstances so we can complete our assessment? But absolutely, you've got a duty of care to yourself and your staff to not let them get injured. And that's what you would document, and that's what you would justify the decision with if someone was to ever question it.
Yeah, and as long as you activate the hospital system in that setting, it's fine to stand aside, say, mate, the door's over there, I've opened it, you're free to go. And I'll tell a cautionary tale about this as well. The person starts heading for the door, that's fine. What you must do then is reach under the desk and push your alert buzzer or caller code, whatever your behavioural disturbance code is, activate your security response, show that the hospital is attempting to stop this person leaving, but you as an individual cannot be held liable or negligent for not doing so. The one proviso to this situation, which I have found myself in scarily enough once or twice, which is why it's really important to always remember that it's okay to back out and call security early, is when you say, mate, the door's over there, you're free to go, and they take 3 steps and they change their mind. And then they turn around and they won't go. And then all of a sudden you're stuck in a room with the person. And if you haven't triggered the security response, that can be a really dangerous situation. So yeah, I think that's a great discussion there of the nuances of how we do this as expert clinicians, because it can be really tricky. One other point I'd like to make is if you do find yourself in these situations with an angry person, my general approach is to always remain at least 2 arm lengths away from them until I feel the person's contained safely enough for me to get close enough to, say, do a physical examination or touch them or examine them or do what I need to do in a safe fashion. The reason for that being that should the person suddenly just decide to lunge at you, punch you, reach out and grab you, from 2 arm lengths away, you've generally got enough time to react a bit. And should they throw a punch, the energy will have gone out of the punch such that they might hit you, but you're not going to get knocked out or seriously injured. If, Nick, where I'm the doctor and you're the patient who's aggravated and I'm standing within 1 arm's length of you, if you cock your fist to hit me now and just do a fake punch, you can see it's very short distance. I won't have time to get away if I'm I won't get far enough away before Nick's punch really lands square on my jaw and can probably really hurt me by doing that. So
the other thing with body language is standing side on to the patient with non-threatening hand movements. One approach is to keep your hands up but open palms, so it's clear that you're not making fists or becoming, you're not fighting aggression with aggression. So it's a passive calm down, but it does mean your hands are available should someone suddenly lunge forward to fend them off or retreat. And you can more easily retreat from a side-on stance than you can if you're square to a patient. So
yeah, great. So we'll get on to how you actually do assess these patients clinically in a moment. But I think it's really important for people for us to emphasise for people to remember that you can't safely physically examine these people or assess them until they're contained. And there's no rush or urgency to do that. And you're much better waiting until the person's perhaps a bit sedated on a trolley with security present before you actually physically approach them, start putting drips in or taking bloods or physically examining them. So we talked about this activating a security response, Ingrid. So hospitals have a code system normally for activating a security response. There's different colour terminology for that. Where I work, it's a code grey. Some places it's a code black. Some places a code black means a threat with a weapon as well as a behavioural disturbance. So what's an ideal way for these codes to be actioned and to progress in an emergency department?
So in our department, Andy, this is a multi-person approach. So a code activation, we would have security come as well as all the available staff within our emergency department. And certainly we might not necessarily need all those people, but they will come and check what's going on. And someone will be the clear lead. Often if there's an ED consultant present, that will be the ED consultant or the most senior ED registrar that's there at the time. Usually at this point in a code, there's still verbal de-escalation going on, but you are also showing a show of force to the patient, which may be enough to intimidate them to de-escalate at the bedside. In parallel with this going on, there will also be nursing staff pulling around the restraint bed that we have pre-made always in our emergency department. And we will also have nursing staff getting some intramuscular droperidol ready to chemically sedate the patient as required. So we are, whilst working towards verbal de-escalation, we would also be preparing for the next level of escalation for the patient, which would be chemical sedation and physical restraint until we can get hold of the situation. Certainly, we routinely do this and we have well-practiced staff that are comfortable doing this scenario, and we work closely with our security service who also are well-trained in not escalating the situation and annoying the patient to the point of irritating them to escalate further. And when we do get to the point of needing to restrain the patient physically on the bed, it's a multi-person, minimum 5 people positioning, 1 at each limb, somebody looking after the head, making sure the patient is on their back and not prone, and with immediate intramuscular sedation given.
Nick, and what about you? Is that sort of how you approach it?
Absolutely. And I think there's some key themes that can make this safer than other times I've seen it done where things have gone wrong. So one thing that's a really high level skill to do is, if the time allows, to have a little pre-brief with your security team when they arrive and explain the scenario and the expectations, because there's cases where you think we're in with a chance here of verbal de-escalation, so let's just be ready but not jump in. And there's cases where clearly the situation is escalating too rapidly and you need the security just to get involved straight away. And again, we're fortunate to work with extremely well-trained security guards who are experts at not unintentionally escalating the situation and will follow the medical leadership in that scenario.
Yeah, that's a great approach, Nick. I also think it's really important for doctors to remember what their role is in this situation, and it is almost universally unnecessary for you as the doctor in charge or as a member of the medical staff to need to be one of the people physically holding the person down. We're not really trained specifically for this. You will find yourselves at times sucked into situations where there aren't enough staff and you might need to. But you need to be super mindful that this is out of your area of expertise. Your role there is as a clinician, and it can actually really impair your therapeutic relationship with the patient down the track if you cross that boundary and become a physical restrainer. Patients remember this. No matter what medication you give them, you come back an hour later and they're like, you helped hold me down, I don't want to talk to you. That can be quite damaging. So it's also important, I think, to maintain your role as someone who examines and prescribes treatment and controls the situation, and let the security staff do the physical handling, let the nurses do the administration of medication. That can maintain some relationship.
I think speaking to everybody's got different practice environments, and I've certainly worked in small EDs or community environments where unfortunately it's just not feasible to have a team leader medically distracted from the actual process. But I totally agree that the ideal situation is like trauma, to have a team leader who's the senior clinician standing back, who's not physically or emotionally invested in the actual restraint process, to make some reasonable, balanced clinical decisions depending on how things are progressing.
I think it's also worth differentiating too, if you are going to become part of the team that's physically holding the person down. There's a difference between, for example, the 40-kilo grandmother from the nursing home with dementia who's flapping around and trying to hit the nurses, who you may just need to help hold still for a while, compared to the iced up MMA fighter who's kickboxing in the hallway, in whom you would almost guaranteed be better off letting leave the department and calling the police than trying to go in with an inadequately prepared team or equipped team to do that, that's relying on a couple of doctors and a couple of nurses and maybe one security guard to help hold them down, because you will find yourself very badly injured. And remembering that these patients are sometimes brought in by police, for example, and before they got to hospital needed a couple of cans of capsicum spray, some handcuffs, some batons and a German Shepherd to contain them enough, and a divvy van or a police van to contain them to get them to hospital. And all of a sudden we release all these restraints and somehow expect a couple of doctors and a couple of nurses in a peripheral hospital to be able to contain them. That's just unrealistic. So I think, gauge the situation on its merit. And if you think you don't have enough staff to safely physically restrain someone, just be really careful and potentially let them go. So on that note, when we're looking at physically restraining someone, there's a couple of options for what position to put them in on the bed. Ingrid mentioned having a restraint bed, which is usually an ED trolley with straps, Velcro straps and restraints already applied, so that it's very quick to put the person on and do a 4-limb restraint. Nick, is there any tips you've got for people about restraint position?
Look, restraint is a really complicated and challenging area in emergency medicine. It's also had a lot of international papers being published about how we should be moving away from physical restraint where at all possible. I think we can all speak to our practice where it would be very hard to envisage practicing as we do safely without being able to sometimes resort to physical restraint. But I think we must remember that it's got to be done judiciously, sparingly, only when necessary, and as safely as possible. So we've pivoted to using only soft restraints, and soft restraints with enough play in the straps so that the patient can still change position slightly to get more comfortable. Those restraints should only be on for the minimum amount of time possible.
So that usually means until such time as you're able to administer some intramuscular and then potentially intravenous sedation, get the situation diffused, the patient sedated, and then look at slowly removing them.
Absolutely. And that has to be, again, a senior clinical decision, because it's always a risk-benefit trade-off as to what the risks are of the patient re-escalating.
And are there risks to physically restraining and sedating someone in a supine position on a bed, so they're flat on their back on an ED trolley?
There's risks to restraining someone in any position. It's absolutely incorrect to restrain someone in a prone position, because there's...
By prone, we mean laying on their
front.
front.
Laying on their front. I've seen a prone restraint death in an emergency department. It's extremely difficult to maintain adequate ventilation when being restrained prone. And although it's still part of some police training and protocols, it's something we should never do in
I think
hospital setting.
Internationally, there's been a couple of extremely high-profile cases just in the last couple of years where, particularly in America, where people have been restrained, hands behind the back, face down on the ground, and that's resulted in death. And that is something that must never, ever be done in an emergency department setting or by an ED security guard. If you see one of your security team forcing someone onto the ground on their front with one or two arms behind their back, you must get them to stop that immediately. You have to turn the person on their side or flat on their back and restrain them that way. And there's very clear physiologic reasons for that. And you'll hear people say, I've been involved in a couple of cases where I came in late, someone was prone, and if you hear someone ever saying the words, "I can't breathe," that is an absolute red flag emergency, that person is 30 seconds to 60 seconds away from a cardiac arrest, and it will be unrecoverable, because what happens is when you force someone on their chest, you're compressing the chest so they can't actually breathe, so their sats will start dropping, they'll be deoxygenated, their heart rate will be through the roof, so they'll be extremely tachycardic, the myocardial oxygen consumption goes up. Often that abdominal compression while they're on their front also impairs their ventilation, so they just can't get enough air in, and it may even decrease their venous return, which when you add all these up, and again, these might be people who are already on stimulant drugs, who are maximally sympathetically activated, a bit coronary vasoconstricted, you can see how all this is adding up very quickly to myocardial ischemia and sudden cardiac death or arrhythmias. And the problem is, should they have a cardiac arrest and you flip them over on your back or on their back and you try and resuscitate them, you're starting from a terrible place in a resus, which with is someone who is maximally deoxygenated in a maximal anaerobic state, already acidotic, and you're starting your rest at that point, they can be unrecoverable as well. So I think that's a really important point to drill in there. Never ever do prone restraint.
100% agree. And you can make restraint should be done on the patient's back. And what I usually do is get them into the soft restraints, establish whatever chemical restraint is required to get control of the situation. And you're always looking for what's the minimum amount I can use to maintain control. And after the patient has started to settle down, that's the important time to think about your secondary survey, going over the patient. I usually elevate the head of the bed by 30 degrees, like you would do for an intubated patient, to minimize the risk of aspiration and to just take a little bit of weight off the thorax so that they can ventilate more easily, slightly upright, and have a discussion with your nurse that's going to be nursing them with 1-to-1 ratio, saying, let me know if there's any respiratory embarrassment occurring, any change in the observations. And as soon as we both agree, we'll be looking to take the soft restraints off.
Yeah, I do a similar thing, Nick. So I think it's important that once you've got the person on a bed, you may be applying the restraints. And one thing we didn't really talk about, which may be part of this sequence, is if the person was, say, in handcuffs with the police on an ambulance stretcher or in a police van, that's an exchange time, isn't it? Where you might do some IM sedation, pop them on the ED trolley, never leave someone handcuffed in an ED, obviously. Take the handcuffs off, apply the soft restraints, put them on the bed, attach your monitoring, very quickly establish IV access. If I give a practical tip for IV access in these patients too, I try and avoid the cubital fossas if you can, or don't put them both in the cubital fossas. Try and do back of the hand, or preferably cephalic vein in the forearm is a great option, because should someone wake suddenly, and I've definitely been involved in this more than once, and it's a terrifying situation, the first thing people do when they want to get out of restraints is flex their elbows. And if you've got 2 cubital fossa IVs and someone does this, all of a sudden you're in this wrestling match to straighten their arm out to get the medication in. Whereas if you've got a forearm vein, and the other thing is if your soft restraints are on the wrist and they're pulling down against them, sometimes they'll pull the IV in the hand out, or it just doesn't flush that well. So if you've got a forearm vein, you'll be able to get access to it really easily in someone who's trying to break out of restraints if they're still really agitated. Another thing I do slightly differently, Nick, and again, there's different practice to this, is if the person's heavily sedated, I'll keep them generally supine as long as they don't have a large abdomen that's impairing the ventilation. Because if they don't have a cough or a gag and they're really sedated, should they vomit, it's much better to have them supine, because if they're sat up a bit, the vomit will just run straight into their lungs, and it also gives the nurses time to just roll them straight onto their side, which is what you do to someone who's obtunded and vomiting, is just get them in a left lateral position. And sometimes even being mindful if the person's really heavily sedated, sometimes having one arm released from the restraints early in case that happens and you need to roll them quickly is quite reasonable, because you don't want the nurse there trying to undo a restraint while an obtunded person has vomit coming out of their mouth.
Yeah, one other thing I'd just like to reinforce is just because this patient is having an acute behavioural disturbance requiring sedation, we must always be conscious of patient privacy as well. And it's a situation where patient privacy is often neglected. And even for a member of the public or a family or another patient in the department, it is quite confronting to be exposed to this situation. And there is always a small level of risk to other members of the public that happen to be in the department. So trying to be conscious of privacy, pulling the curtains for respect for the patient and for the rest of the department is a really good idea to try and keep that foremost so it's not forgotten about.
And Ingrid, do you have any other tips about nursing the sedated or restrained patient?
Yeah, I think there's 2 important points to add to what you have both said here, and that is that it's important to maintain vigilance on this patient once you've chemically sedated and restrained them. It's an iatrogenic thing that you've now done to this patient, and you are responsible to make sure that they are ventilating and breathing safely. So all these patients need to be in a monitored environment with a SATS probe on as a minimum. Certainly, once their heart rate and blood pressure have settled, it's reasonable that they don't necessarily need to be on direct cardiac monitoring, but we do need to make sure that they maintain their ventilation. It's not uncommon for these patients, once they've settled after a couple of hours, to get put into the back cubicle of an emergency department and ignored, and that's an extremely dangerous place to be for a patient that you've made unconscious.
Yeah, we have pretty strict criteria about someone moving, say, out of resus into a normal cubicle or perhaps into our short stay area where they have to be alert, responsive, vital signs normalising, not at risk of reobtunding from the sedation you've given them. Some people also, on the flip side, wake up sometimes very suddenly, sometimes very gradually, and remain agitated, combative, psychotic, otherwise needing ongoing care, and sometimes require repeat dosing and just need to stay in that monitored environment. It's extremely resource intensive and can be quite draining on the nursing staff dealing with someone who's potentially a bit abusive or violent or threatening. So you do need to support your nursing colleagues. And I think one of my things that I generally do in this situation is right at the start with that situation when the person's just gone to sleep, is I actually try and hang around in the cubicle with the nursing staff for a good 10 or 15 minutes minimum. Number one, just to make sure that the drugs are working. Do they need a top up? Have we given them too much? Do they need an airway adjunct? Give the warders time to settle before you just give the drugs and walk out. Because I've definitely seen and been involved in situations where practitioners have done that. Drugs go in, I'm really busy, and they run out, and either the person deteriorates or wakes up and hits the nurse, or it just adds too much strain on the nursing staff. So I think just be aware of your colleagues in that situation, support them as best you can, and periodically check in. I think there's also that temptation just to sedate people and walk out and just spend the next 6 hours of your shift seeing other patients and assume they'll tell you if something's wrong. It's really important just to cycle back every hour, especially if someone's physically restrained, because of this need to be proactively managing the de-escalation of restraint.
And I think that touches on this trauma-informed care that Nick was alluding to before. And that holds true for the patient when they eventually wake up, but also for your nursing staff, the other medical officers involved, and any of the patients that have been on the periphery of what's gone on. It can be extremely confronting for the poor patient next door with sepsis to have heard all of this that's just happened. And I do think it's important to try and take the time to talk through with them what's gone on and explain the situation. And I think certainly as medical officers, we can review the situation and acknowledge that it can be very intimidating and frightening for us. But I do think that it's really important to acknowledge that the nursing staff are often more frontline than the medical officers in these situations. And certainly, especially with chemical sedation, it can take some time for the patient to actually become unconscious. And it's often the nurse that has to stand there with the patient while they become unconscious. And this period can be when that patient is yelling all kinds of abuse at the poor nurse that's there, reading their name tag, telling them that they're going to come and kill them, say that they're going to find out where they're going to go and live. So, I think just being cautious and aware that the nursing staff have to put up with a lot in these situations.
I think you really touched on an important point there that we kind of forgot to mention is, this isn't punishment, but it can definitely be perceived as such by the patient. And I have a colleague from Darwin who's looked into this a lot, and patients remember everything that happens in these situations a lot of the time. It's extremely scary, confronting. It is completely disempowering for the person, and it is really important at each step of this process to at least attempt, if the person's just in a wild rage and unable to comprehend anything you're saying, you might skip this step. But if you are physically restraining someone, it's still important to stay calm, explain why you're doing it, that we're looking after you, that it's for your best interest. You might not think right now. Apologise. Don't be shy to say, look, I'm really sorry, but we've made a decision. This is what we're going to do, okay? We're going to do it for the shortest amount of time as possible. We want to give the control back to you as soon as we can, and just keep that person informed along that journey so that the trauma on them is as little as possible.
I mean, also have to remember our just duty of care to be mindful that this is quite a high-risk cohort for other medical problems. So once you've established the restraint and control of the patient, I usually try and do a thorough secondary survey looking for injuries, which you find relatively commonly, often minor injuries, but occasionally significant head injuries that just hadn't been overtly obvious until that point. And then also referring to the patient's electronic records, seeing if they've got significant background medical problems that might need to be reviewed while the patient's here.
And I've definitely heard of cases of things like meningococcal meningitis and encephalitis being missed in these patients who are presumed to be on drugs or psychotic and have had a takedown and a prolonged period of restraint and a justification for their abnormal vital signs being, oh, well, they're on drugs, that's why they're a bit hot and a bit tachycardic, but not realising that that's continuing when the drug should have worn off. And things like CNS infections can definitely present this way.
It speaks to the dangers of diagnostic anchoring, and once the adrenaline of the situation settles down, re-waking up the thinking part of the brain, the type B thinking, get a collaborative history, speak to the family, find out if this is expected or completely out of the blue, and then try and make a good faith differential based on that, rather than just assuming it's necessarily drug effect.
Thanks, Nick. That was a great discussion, and thanks, Ingrid. So it's really important to remember ED is a really difficult and stressful place to work sometimes, and this is a really common, essentially almost daily or multiple times daily occurrence in our EDs. There's some really salient points we pulled out there about building good relationships with your security team, sometimes involving them in simulation training and practice around this sort of process to smooth it out, get your protocols and your guidelines and your processes sorted out in your department. And I think lastly, just remembering that concept of safety, both for you, your team, your department, and the patient. All right, thanks for listening to the ToxCourse podcast. I hope you found that useful and can take some tips and pearls from that discussion back to your next shift on the floor. Acute behavioural disturbance is a very common but sometimes really tricky area of our day-to-day work. And look, I really think the key take-home message from this discussion is that your safety is paramount and you should never feel obliged to put yourself in harm's way at work. Trust your gut feeling or your spidey senses, if that's what you want to call it. And if you feel threatened in any way by an agitated or behaviourally disturbed patient, it's actually okay to back out of the situation, summon help, call a co-grey or activate your security response or your duress alarm, and never ever stand between an agitated patient and the door without some big burly security guards or police between you and the patient. And if you can't get those people there quickly enough, it's okay to let the person go and then continue activating your security and police response. Anyway, if you'd like to learn more about emergency toxicology, please head over to etmonline.com and check out Module 1 and Module 2 of the Tox course. Module 1 includes some really common topics. We do a great introduction to emergency toxicology and I give you a really structured approach to the poison patient. And then we cover some common tox subjects, including the toxicology of opiates, quetiapine, paracetamol, benzodiazepines, SSRIs and SNRIs, and the old classic tricyclic antidepressants. Module 2 is the recreational drugs module, and we cover a great introduction to recreational drug use and toxicity. We do GHB or gamma hydroxybutyrate, MDMA and LSD, white powders, essentially cocaine and methamphetamine toxicity. We also cover inhalants, which is mainly nitrous oxide, and that's a great module there, a great lesson on that topic, which is becoming increasingly common. We're seeing more and more of that in the EDs now. We also cover cannabinoids, cathinones, vaping and nicotine, and stimulant-induced movement disorders. That's a huge module. It's fantastic. We've also just finished recording Module 3, which covers some other common and tricky tox topics, including aspirin, digoxin, beta blockers and calcium channel blockers, the ADHD drugs, dexamphetamine and methylphenidate. We cover clonidine and guanfacine, as well as gabapentinoids and baclofen. And we do a quick overview of decontamination and enhanced elimination. So that's going to be hopefully released in the next couple of months. We're just in the process of editing Module 3 up now. And in big news, we're actually really excited to announce that we're booked in to record the much anticipated and much requested toxinology or bite, stings and envenomation module with a very special guest expert. Big surprise coming with that later this year. I think it might take us a while to edit. It's going to be a huge module, but it's going to be fantastic. So please head over to etmonline.com and check out the Tox Course modules, and we'll see you in the next episode of the Tox Course podcast.